At the outset, I'm thankful to Dr. Neglur, Dr. Sanjay and Neeta having given me this opportunity to be part of this very prestigious conference. Well, task assigned to me is non-diabetic hypoglycemia, rather a boring topic. I was not very keen on talking on this topic, but well, you don't have any option when you opt for only a day that you want to come on Sunday, so what's your slots and topics are left behind are always offered to you. So, but still I'll try to do justice to the topic. Well, physiologically talking, whenever there's a hyperglycemia, it stimulates pancreas to secrete more insulin. There is an increase in insulin circulation, which improves or increases uptake of glucose into adipose tissue and muscles, and also leads to glycogen synthesis, and then there is a decrease in blood pressure, which physiologically happens. Contrary to that moment, there is a hypoglycemia, it stimulates pancreas to secrete glucagon. There is a overstimulation of alpha cell, increases circulating glucagon, which leads to then breakdown of glycogen in liver and immediate release of glucose, so that you are not in severe hypoglycemia unless you have some injuries with that. Well, as Dr. Neglur said, hypoglycemia is classically seen in diabetic patient where you are using insulin, intensive insulin therapies, conventional sulfonylurea or magnetide, but even in non-diabetic person, use of insulin, sulfonylurea or magnetide as a fictitious drug to induce hypoglycemia is not very uncommon. Then alcohol is a very, very common cause of inducing hypoglycemia. Well, there is a huge list of drugs, almost 160 drugs which have evidence that they can induce hypoglycemia. Important ones are quinolones, pentamidine, quinine, beta blockers, angiotensin converting enzyme inhibitors and IGF-1 like drugs. Ethanol, which inhibits primarily gluconeogenesis but does not affect glycogenolysis. Well, if you are on a long spell of alcohol binge with limited ingestion of food, it will result in hepatic glycogen depletion also. Sepsis, again, conventionally it is thought it leads to severe hypoglycemia, but still it is a common cause of inducing hypoglycemia with cytokine which accelerate glucose utilization towards the periphery, and you are in a phase when you have already glycogen depletion and there is inhibition of gluconeogenesis also. CKD is a very, very common cause. It is said in a diabetic, well, topic is non-diabetic. In a diabetic, first time you have an episode of hypoglycemia, look for if patient already has reduced EGFR. But even in a non-diabetic person, chronic kidney disease, because not only introduces hypoglycemia because of recirculation of available insulin, but also because of reduced renal as well as hepatic neoglucogenesis, severe liver failure. Through both the mechanism, gluconeogenesis and glycogenolysis are again common causes of hypoglycemia. Cardiac failure per se may be probably because of hepatic congestion and hypoxia, again impairing glucogenesis and glycogenolysis, and malnutrition because it can cause hypoglycemia as a result of substrate deficiency which happens in these patients, which is commonly seen in anorexia nervosa. Then various hormone deficiencies, maybe cortisol deficiency or growth hormone deficiency, or overall endocrinopathies like adrenal insufficiency inducing glucocorticoid or cortisol deficiency, growth hormone deficiency through hypopituitarism, both together seen in pituitary diseases like decreased combined corticotrophin and growth hormone deficiency, and even glucagon deficiency is one of the common cause of getting non-diabetic hypoglycemia. Various neoplasm, Dr. Neglur, we chaired the morning session where there were 2-3 interesting cases. One case was insulinoma, another was non-secreting, insulin-secreting tumor. There are a huge list of tumors, non-isolate cell tumors, mesenchymal tumors, hepatocellular carcinomas, adenocortical tumors, carcinoid tumors, leukemia, lymphomas. In fact, we told that delegate, that speaker, that patient had one lymph node in the axilla, which was picked up on PET, and they didn't do FNAC because they found that there was other cause of hypoglycemia in that patient. And most of these tumors, what they do is they secrete IGF-2 type-like molecules, and they also secrete glucagon-like peptide many times, so that induces hypoglycemia. Then insulinoma, classically a pancreatic beta cell tumor which will secrete insulin. Most of the time, fortunately, they are benign, about 90% are benign, and they are solitary small tumors, but very fact that you are not able to inhibit insulin secretion at the time when your sugar is already dipping down, that induces severe hypoglycemia in the setting of insulinoma. And diagnosis come with very high insulin levels, spiral CT, arteriography, ultrasonography, or maybe CT or MRI abdomen can get you to the diagnosis. Treatment of choice is, well, you need to remove the tumor, and recurrence at 10 years is about 6%. At 20 years, it is about 10%. Then isolated cell hyperplasia, no tumor, also called as acidoblastosis or diffuse isolated cell hyperplasia or syndrome of non-insulinoma, pancreatogenous hyperinsulinism, again is a very common cause, especially seen in those patients who have gone for bariatric surgery or Roux surgery when you have overproliferation of remaining beta cells. Then it also may be a part of MEN1, multiple endocrine neoplasm, where common tumors are parathyroid, isolated cell of pancreas, or pituitary gland. So it may be sort of progressing of the same disease that you might get hypoglycemia in the beginning and subsequently might come to know number of malignancies which are part of MEN1. Then persistent hyperinsulinemic hypoglycemia of infancy, which is PHHI. These infants, they have identified genetic mutations which are there in sulfonylurea receptor, that is SUR1 or KR6.2 or even in glucokinase. So they have persistent hyperinsulinemia which leads on to hypoglycemia, which is very, very severe in these children. Then autoimmune causes, anti-insulin receptor antibodies rarely can induce hypoglycemia, because what happens is that these autoantibodies, they bind the insulin receptor and they mimic the biological action of insulin. So there is a persistent hyperinsulinemia which is seen in these patients. You do their ESR may be high, they might be positive for ANA also. Then anti-insulin antibody, again antibodies against insulin. What they do is they bind free circulating insulin when insulin levels are high. And as insulin level go down in the fasting stage, what happens is they might suddenly release huge amount of insulin disproportionate to the meal intake. So it leads on to a severe hypoglycemia episode. Symptoms of hypo, classically adrenergic symptoms usually seen with early and rapid decline of blood glucose, which has like typical tachycardia, tachypnea, vomiting, diaphoresis. Subsequently, neuroglycopenic symptoms, which could be simply like headache or clouding of ideas, poor feeding, altered mental status, lethargy, at times seizures, and patient might actually go into coma also. To classify hypoglycemia, fasting is a typical which is seen in delayed post-absorptive state, maybe after 3 to 4, 5 hours of meal. And reactive postprandial hypoglycemia, well, that is controversial, whether it exists and how significant it is. Usually you see low postprandial plasma glucose levels, but they are not enough to take you to the diagnosis, because 10 to 30% of normal individuals, once you do an oral GTT, might have sugars less than 50 and they are not symptomatic at all. Only patient with severe loss of consciousness, or they end up with some trauma, injury, or meet an accident, and they are in the postprandial hypoglycemic phase, probably need to be investigated in detail. Then dumping syndrome or elementary hypoglycemia is when it presents within 2 hours or around 2 hours after a meal. There is a disruption of controlled gastric emptying. So what happens is that there is a decreased transit time. So there is a rapid elevation in plasma glucose which stimulates insulin to very high levels, and this abnormal insulin peaking leads on to a fall in blood glucose and severe hypoglycemia. So when we talk of pathophysiology of hypoglycemia, responses to hypoglycemia is our ability to suppress insulin in response to hypoglycemia. Whenever you are, say, giving insulin, you remove insulin, sugar will obviously then start settling. If patient is on long-acting sulfonylurea, it might still continue. That is what happens classically in diabetics. That is why in elderly patients, we say that use short-acting drugs so that they don't end up with severe hypoglycemia. But in non-diabetic persons, again, main defense is increased release of counter-regulatory hormones like glucagon, epinephrine, cortisol, or growth hormone. Glucagon stimulates both glycogenolysis and neoglucogenesis from the liver. Epinephrine, what it does is it stimulates beta-adrenergic receptors, so it will improve glycogenolysis as well as neoglucogenesis, but will also work through alpha-2 receptors to inhibit insulin secretion. Cortisol and growth hormone, they contribute only after prolonged hypoglycemia, especially growth hormone, and cortisol may be seen rising after 7 days of prolonged hypoglycemia. Counter-regulatory effects of epinephrine, as I said, These could be direct effect to the beta cell. So there is an improvement in glycogenolysis and immediate neoglucogenesis to check severe hypoglycemia. It may also stimulate alpha-2 cells, so reducing the insulin levels. But what it may do through muscles also, it will reduce utilization of glucose towards the periphery so that hypoglycemia is checked. And through fat, it will induce lipolysis actually to correct hypoglycemia so that more substrate is available for neoglucogenesis. Glucagon and epinephrine levels usually rise when plasma glucose starts falling closer to 70. So between 65 to 70, you might have immediate response in terms of glucagon and epinephrine, but growth hormone will come when sugar is falling towards 60, and cortisol, as I told you, might come only if sugars are going very low, less than 60, when you are in true neuroglycopenic phase. To come to the diagnosis, it is important to go into detailed history, look for signs of liver failure. If patient is in sepsis, look for autoimmune diseases, or a history elaboration might take you to the diagnosis. Then various neoplasm, I have listed a huge list, then alcohol and various drugs. If you go in detailed history, probably you might pick up. Getty has been now withdrawn from the market only because it was inducing severe hypoglycemia in diabetic patient. But many quinolones, even Oflox and other quinolones, are also leading on to hypoglycemia in various diabetic patients who are on treatment for, say, simple UTI on outdoor basis. To establish fasting hypoglycemia, what you need to follow is a 72-hour supervised fast test. It should be ideally done in a hospital setting to lower risk to the patient, because at times sugar might go very low, 40 or 45, and patient might have some injury. And usually hypoglycemic episodes, these happen within 48 hours in most of the patient, maybe 95% of patient. Within 48 hours or 42 hours, you might have sugars going very low, closer to 50 milligram. So protocol is that date the onset of the fast as the time of last intake. Moment patient is in the hospital, stop all calorie drinks, discontinue all non-essential drugs, only allow calorie-free or caffeine-free beverages, and usually a warm water, and collect blood samples for measurement of plasma glucose, look for insulin level, C-peptide and pro-insulin level. This is what Dr. Negloor, we pointed out in that insulinoma patient, they didn't do all these things. So that was a discredit to that person who was talking about insulinoma. And what you need to do is, moment sugars are falling less than 60, then it has to be repeated every 1 hour, initially every 6 hours. So test will end either if glucose is falling less than 45 milligram, or patient has symptoms of severe hypoglycemia, or 72 hours have already passed. So you will, in any case, you will abort the test, or when plasma glucose concentration is less than 55, but you have classical symptoms, what you see in a Whipple's trial, and you also look for plasma beta hydroxybutyrate and sulfonylurea to pick up other causes of, I'll be telling you how to pick up other causes of hypoglycemia. And as a corrective measure, you give 1 milligram glucagon, maybe subcutaneously or intramuscularly, and check sugars 10 minutes, 20 minutes, and 30 minutes, so that patient is back to more than 100 milligram%. In normal subjects, falling thresholds have been identified. We are not talking about diabetic patient, non-diabetic or normal population. So once sugars are falling closer to 80, insulin secretion starts decreasing physiologically, and it is followed by an immediate increase in glucagon and epinephrine, almost closer, as I told you, 65, or once it is less than 60, even cortisol level will start going up. Normal subjects don't have symptomatic hypoglycemia even after a prolonged fast. So that means they will not dip, say sugar will not go as low as 30 or 40 milligram, because that is how so many Jain fasts are going on. Anna has been fasting for 13 days without getting any severe hypoglycemic symptoms. So a normal person will not dip into a very low sugar. Gluconeogenesis accounts for approximately 50% of glucose production during this fasting phase after an overnight fast, and within 42 hours, most of the energy will then obviously come from neoglucogenesis. This is how you interpret values after 72 hours fast. Look for insulin level, C-peptide, pro-insulin, sulfonylurea, and insulin antibody in every patient who is going for this test. If insulin levels are high but C-peptide is low, pro-insulin levels are low, you cannot detect any sulfonylurea-like drug or insulin antibody. Obviously, that means patient is has been taking exogenous insulin. So only insulin levels are high, there is a suppression of C-peptide. So if insulin levels are high, C-peptide is high, pro-insulin is also high, that means there is insulinoma, right? Because C-peptide is high, there is an overproduction, pro-insulin level are also high, and this ratio may be more than 1 also. And if same setting you have insulin levels high, C-peptide high, pro-insulin is also high, and you have presence of sulfonylurea-like drug. Of course, you'll have to test it in the lab. Then that means patient has been consuming sulfonylurea to have a fictitious type of hypoglycemia. Look for C-peptide, insulin, and pro-insulin. All are high. No sulfonylurea-like drug, but they have insulin antibody positive. It belongs to autoimmune type of variety of hypoglycemia. Most likely insulin autoimmune type of hypoglycemia. And if only insulin levels are high, C-peptide is low, pro-insulin is low, that means you have receptor antibodies. So these patients might respond very well to steroid therapy immediately after therapy. So interpretation of this 72-hour fast, a diagrammatic representation, look for plasma glucose responses to glucagon. So in a person who already had episode of hypoglycemia, and after giving glucagon 1 milligram, if your plasma glucose is going more than 25, that means this patient has insulinoma, 1. Now again, look for plasma insulin concentration after a prolonged fast in someone who already had hypoglycemia, and if plasma insulin secretion are above 30 milligram, above 30 picomoles, that means this patient has insulinoma. And again, look for C-peptide concentration after a prolonged fast. If patient had episode of hypoglycemia, look for C-peptide levels. If these are more than 0.2, that means this patient has insulinoma. And look for pro-insulin concentration after a prolonged fast. If it is more than 5 picomole, again this patient has insulinoma. So that is how we try to interpret the result of 72-hour fast in these patients once they are hospitalized. So a simple algorithm for these patients could be that someone who is having suspected hypoglycemia, if patient is a known diabetic, look for whether patient is on overdose of insulin or there is a mismatch between calorie intake and insulin, or patient is on long-acting sulfonylurea. If patient is a non-diabetic and C-peptide levels and insulin both are low, no, both are high, look for sulfonylurea values. If these are not there, only C-peptide and insulin is high, that means patient has insulinoma. If sulfonylurea-like drug is positive, that means patient has been consuming sulfonylurea in an attempt to induce hypoglycemia. If insulin antibody is positive, that means it is an autoimmune type of hypoglycemia. And if C-peptide is low but insulin levels are high, that means this patient has exogenous use of insulin in a non-diabetic setting. That is how we can interpret results of hypoglycemia and 72-hour test. Principle of treatment are priorities to immediately correct sugar, bring it more than 50 milligram, maybe either with oral, if it is a mild to moderate type of hypoglycemia. If patient is already in neuroglycopenic phase, maybe an IV dextrose. Second priority is to address the underlying cause. If it was insulinoma, a surgical remover, or if it was a hormone deficiency, maybe substitution of those hormones in the form of injectable steroids might help in these patients. And those patients who have autoantibodies positive, they respond very well initially to efcorling-like drugs, and subsequently they can go back on prednisolone on tapering doses. Most episodes of asymptomatic hypoglycemia and mild to moderate symptomatic hypoglycemia are effectively treated by simple ingestion of oral glucose, which may be in the form of juices or soft drinks or milk or something, or it may be a candy. But recommendation is usually you must have at least 15 gram of glucose and check sugar every 10 to 15 minutes, a rule of 10. However, the glycemic response to oral glucose is usually, it will not last very long. So there is a chance the patient might dip into hypoglycemia again. So you need to check sugars every half an hour till patient has sugar more than 100 milligram percent, and keep repeating 15 gram glucose every half an hour. A parenteral treatment is necessary when hypoglycemic patient is sort of in a neuroglycemic phase or cannot take oral, then you might have to give an IV drip in the form of 25 or 50% dextrose, or maybe a 1 milligram injection of glucagon, which is more effective in type 1 than in type 2 diabetic patients. And hypoglycemia related to endogenous hyperinsulinemia is often curable by surgical removal if it was a insulin secreting tumor. If this is not possible because of multiple metastatic, I told you many malignancies might have severe hypoglycemia, so those patients might do well on diazoxide long-term on 100 to 800 milligram per day doses, and it corrects hypoglycemia. Well, the side effects are that you might have brain edema and gastrointestinal side effects, at times hypotension because of high dose of diazoxide. And other treatments include, of course, you can use injectable or infusion octreotide or even calcium channel blocker, because that will immediately check the release of insulin from the beta cells. Short-term treatment of hypoglycemia is usually in the form not beta cell tumor. You need to do radiotherapy or maybe a chemotherapy or a surgical removal of non-insulin secreting tumors. Remission of autoimmune hypoglycemia, I told you, is best with immunosuppressive therapy or maybe high doses steroids. And treatment of hypoglycemia related to hepatic or renal or cardiac failure, you need to primarily treat the cause to get back to normal values. A word about hypoglycemic coma, recovery from hypoglycemia at time may be delayed. So if after correction of sugar, getting it back to more than 100 milligram, after 30 minutes, if patient is still unconscious, this patient could be into hypoglycemic coma. Just to exemplify, give you two examples, live cases. 39-year-old man was referred for evaluation of repeated episodes of sweating, slurred speech and confusion during last 4 years. That could be aborted by overeating. So patient was constantly gaining weight. 2 occasions patient met with a car accident when sugar was 30 to 40 milligram. And after that 72-hour test, within 12 hours he began to sweat. He went into severe hypoglycemia. Glucose was 22 milligram. Insulin levels were extremely high. C-peptide was very high. Pro-insulin was also very, very high. So the glucose increased after glucagon. So this is classic, and sulfonylurea was negative. So this is classical, what is an insulinoma. And the second case is 27-year-old man who was referred for by his local physician for a workup for peptic disease, and it was found that, and patient already had a surgery about 2 years ago for morbid obesity in the form of bypass, and he was still getting episodes of hypoglycemia. Glucose was 36 milligram. Insulin levels were high. C-peptide was low. Pro-insulin were low. So what is the most likely diagnosis? Is it insulinoma, insulin antibodies, exogenous insulin administration, or elementary hypoglycemia? In this patient, if you see C-peptide and pro-insulin levels are they indicate that there is a hyperinsulinemia, but it is possibly because of exogenous insulin release, because C-peptide and pro-insulin levels are not very, very high. Thank you very much for your patience listening. If you have any questions, I will be more than happy.
Thank you. Any question anybody has? Very interesting topic. Anybody? One question? Anybody? She wants to ask a question.
Yeah.
Sir, we have seen reactive hypoglycemia in diabetic patients, but sometimes a non-diabetic presents with typically complains of post-meal dizziness, and then when the sugar...
I told you, they are in the immediate post-meal phase. You might have many patients getting sugar 50 to 60, but this is very, very controversial because severe hypoglycemia may not be there. And many patients, once they have been subjected to oral GTT, if their insulin levels are on the higher side, maybe still in the normal range, they tend to have hypoglycemia before they become even IGT. So many obese patients in IGT phase have very high insulin levels, and immediately in post-absorptive phase, they might have symptoms of relative hypoglycemia.
And
that can be seen even in non-diabetic persons also.
And should we treat it, or should we change the meal pattern or
Yeah,
something?
they need to have frequent small meals. Yeah. And they shouldn't have too much sugary things, because that will rather increase. Contrary to the belief that you tend to give them a lot of glucose and honey, their insulin level will go up. So give them complex carbohydrate and frequent small 2-hour meals, so that their insulin levels are not shooting up after the meals.
You can give a carbo also.
Yeah.
Thank you, sir.
Thank you very much, sir.
I just had one question.
Anyone question?
Yeah.
I'm coming from eastern part of India. Do we have IGF-2 assay in any part of India? And can you tell me what is the turnaround time, cost, where is it possible?
I'm not sure that it is being done as a clinical practice. as a research tool, most of the institutions which are into the research, teaching medical college, they are doing IGF levels. 1 and 2 both are available.
In Kolkata, actually, we don't have. So I was asking whether in northern India or any
Delhi
part.
it is available. GTB I know they are doing, and AIMS people they are doing. But I'm not sure whether it is commercially available other than the research access. Sulfonylurea they are doing. It is available. Yeah. Actually, as a protocol, you should do sulfonylurea.
Ria College, there's a professor of chemistry who estimates all these drugs, including some of these. I had a patient who came with hypoglycemia to me and he was taking some Baba Ramdev's medicines. And I was sure that he was having drugs like sulfonylurea. And then I estimated that powder content.
Yeah.
He told, the report came
Yeah,
back with
sulfonylurea you can easily detect.
It's powder.
Many of these herbal and all those pudiyas, they have sulfonylurea.
We are doing it in Bombay.
Sorry?
None of the labs are doing
Ria Hospital, Ria College does it. And the arsenic levels are
Shriram laboratory.
Kasturba
they are doing it.
Thyrocare is doing it.
Kasturba Hospital.
But this sulfonylurea,
I got it done through a professor.
because
who
I
was
wanted in
interested.
one patient, I couldn't find anybody
Maybe.
who was doing it.
Not in routine, I am saying.
Yeah.
Not routine labs are doing. Yeah. Not routine in clinical practice. Yeah.
This Babaji is a very fond
And
of
I was so
sulfonylurea.
sure that this has leventhlamide,
yes.
and I just could not pinpoint because no lab was ready to test and
Not
tell
as
me.
a routine
Yeah.
practice. There is one man who sits in South Delhi
Yeah.
near Palam, near airport terminal
Yeah.
1. He has been a cycle repair.
Yeah.
He has huge practice of diabetes. Moment, you believe me, he sees more than 60, 70,
Yes.
80 patients every day. What he does is he has small slips. Earlier days he was giving glycomet GP1. Sorry, I'm branding. He was giving glycomet GP1 and what he does is he gives you one orange colored liquid. Moment you go as a diabetic person, he induces hypoglycemia in 7 days time, and then 3 months, 2 months, he says that your diabetes has been cured and beta cell has been stimulated. Patient is very happy because then they start withdrawing their drugs and they are comfortable.
I also have kept a cycle outside my clinic.
That is why you are flourishing.
Problem is no labs are doing it, so you can't really pinpoint and expose that this is the drug that is present
No, I
in your
agree.
mixture or something.